There can be a misconception that diagnosis is a single event that takes place at a single point in time. We're here with Victor Lane Rose, Executive Director of Aging and Ambulatory Care at ECRI, to talk about how diagnosis requires the input of providers, patients, and caregivers, and how their input is especially important in diagnosing dementias. Vic, we talk about diagnosis as a multifaceted process. What do we mean by that?
It's a great question, Paul. So like anything, and especially in healthcare and medicine, as we move towards a diagnosis, it's more of a journey than it is an event. And so when we think about all the things that have to happen for any illness in particular to be diagnosed, there's a lot of inputs and there's a lot of interactions that happen to dial in that diagnosis, come up with a working diagnosis, confirm it, and then build a treatment plan from it. When we think about all those inputs, there's the interaction between the clinician or practitioner and their patient, which is just really care critical. That is the process, that two-way communication process where change in condition is first identified many times, change in behaviors, anything that can start to indicate there's a disease process at play. Conversely, then anything that might interrupt that process can start to lead to diagnostic error and other harm, preventable harm that comes out of it. So as we kind of move back in the system then as well, beyond just that relationship that has to be really steeped in trust between the clinician, practitioner, and their patient, there's all the other things that go with it, medical records and the information there, diagnostic testing, and all these complex processes that come together to help that particular physician or clinician come to the correct diagnosis so that the treatment for the patient can begin.
Vic, in this year's Top 10 Patient Safety Concerns report, we talked about the complexity of preventing diagnostic error. What's some of the harm that can result from diagnostic error?
So one of the reasons that diagnostic excellence, diagnostic safety made ECRI's top 10 list this year is annually there's up to 2.59 million diagnostic errors that happen. Of that, there's about 800,000, give or take, episodes, adverse events where there's actual harm or patient death. So when we think about the system and we start to accumulate that harm, it certainly rises to the top. I dare say there's lifetimes of patient safety work that could just focus on diagnostic safety and diagnostic excellence alone. Like many processes too, when there's a problem at the beginning of the process, it tends to cascade through, and then things continue to get worse and the harm continues to increase. So from our perspective, we really want to focus on diagnostic safety. We know that when we get a good diagnosis and we have a good working diagnosis, that the treatment plan that follows is the best opportunity for a patient to find wellness or health.
In our most recent white paper, Vic, we looked specifically at diagnosing Alzheimer's and other dementias. What makes those diagnoses even more complex than other types?
There's a physiological and biological aspect to that. Diagnosing something like Alzheimer's disease is a difficult process to begin with. And there's also some ethical questions that arise out of that even when we start to do certain types of diagnostic testing and we don't have a treatment plan. There's also, when we get into Alzheimer's and other types of dementia, there's a communication problem that happens. And as we talked about with the diagnostic reasoning process, that two-way communication between a patient and a clinician is very important to build that working diagnosis, to verify different changes in condition that are happening. And so anything that interrupts that communication process opens the opportunity for harm to come into it. So when we have someone that has dementia and memory is affected, judgment sometimes affected, communication processes are affected, it just opens up a Pandora's box of potential harm in that diagnostic reasoning and establishing a working diagnosis process.
You talked about earlier, right? I want to understand changes in behaviors, changes in physiological conditions. If I can't tell you what's going on with me, you, the provider, are operating with incomplete information to try to diagnose it.
Absolutely, and I think that's where it's really hard too. A lot of times in healthcare and medicine, when something goes wrong, we go to the healthcare provider, the clinician or practitioner, and we start to look for blame. But the truth is, in a process like diagnosing or diagnostic reasoning, there are so many inputs that have to be managed. When we really look at the system and understand those complexities, consider just for a moment, in today's healthcare system in the United States, when someone has a patient journey, perhaps they're at home, they end up being admitted to the hospital, an older adult, and they end up in a nursing home for a short stay visit, and then back to the home with home care. We can have anywhere from 5, 6, 7, 10 physicians involved in that process. And through that entire process, as that physician or those clinicians are managing that ever-growing medical record, there's diagnostic data coming in. If that information doesn't get handed on even completely, that one factor alone opens the door for continued diagnostic error and harm to come out of it.
Vic, are there examples of initiatives that are currently ongoing to improve that continuity of care for older adults?
There absolutely are. Right now, there is an initiative called Age-Friendly Health Systems. And that initiative really took 4 high-risk areas in caring for and delivering care to older adults. And it's been classified or called the 4 M's. So of the 4 M's, the first one is what matters, the second is mentation, the third one is mobility, and the fourth one is medications. When you get into a disease process like Alzheimer's or related dementia, in so many ways, that process hits all 4 of those M's. When we talk about the diagnostic reasoning process, though, and that trust-building relationship, it's really eliciting what matters that's so critical to forming that initial working diagnosis. That's the process where a clinician sits down and spends time with that patient, understanding what's happening in their lives, what routines may be changing, what aches and pains might be happening, all the way up to some more severe signs and symptoms. Anything that breaks down that process of eliciting what matters can absolutely lead to diagnostic error and harm. So for us, as healthcare professionals, we really need to consider when we have someone who's been diagnosed with dementia, how we go into that process, the supports, resources that we use to elicit what matters. And oftentimes, that's where it falls to a family member or loved one, where communication breakdown happens, and that person becomes a surrogate in the truest sense of the word, helping a clinician or practitioner as they're building the working diagnosis, ordering tests, getting through the testing process. That person really becomes an advocate for the patient and helping that particular diagnostic process to find its true mark.
What are some things that those family members you mentioned, they have to take on maybe a more active role than they have in the past? What are some things that those family members can do to be the right kind of advocate? I don't know the right way to say it, but to be the most helpful advocate they can be for that patient?
One of the first things when you're selecting an advocate, of course, especially where dementia comes into play, the sooner the better. As we're younger, as much as we don't like to talk about certain things, folks that know us for a longer period of time can often help make decisions on behalf or for us in a much better way. Being a surrogate's a tricky thing, and throughout my career, I've helped different folks make decisions on behalf of others. Been in the situation of having to do that. What I found is this: it's so important through the process when clinicians, practitioners, the person themselves remind themselves that in that decision-making process, as they're communicating on behalf, as they're making decisions, you're not making decisions, based on what you would have done, but you're making decisions based on what you believe that the individual you're serving as surrogate for would make that decision for themselves, and still trying to preserve self-determined health care. I think when a family member or a loved one has known someone longer, it's easier to do that. You know someone's preferences, you know their thoughts about things, especially as impairments begin to develop. And I think as importantly, you're there serving then in a capacity for them and not trying to make a decision on what you'd like to see happen to preserve time in some cases. If a patient really doesn't want heroic measures and other types of treatment, you're put in the position to guard their wishes and help bring those into the process.
Vic, is there anything else we want to mention sort of as we help providers drive towards limiting diagnostic errors, especially around dementias and Alzheimer's?
There is absolutely, Paul. I think anytime we start to understand how a system behaves and we start to identify different opportunities for ongoing improvement, That's how we create an environment that's less likely for adverse events to occur. Conversely, when those things break apart or it pulls at the fabric of those processes, it creates an environment where they're more likely to occur. In this case, it really does take, that group of all vested stakeholders that come together, understand that environment where diagnostic reasoning and that working diagnosis is developed, and approach it from that systems perspective, socio-technological aspects, the physical environment, the amount of time we spend with each other and pulling it out. The culture of safety is as critical here as it is anywhere else in healthcare and medicine. We think of 3 subcultures that make up that culture of safety. We think of our blame-free culture, which we mentioned earlier. We don't want to focus, on why a clinician necessarily made a mistake or missed something, but we want to understand the contributing factors that create an environment for that to happen and remove those from the environment as much as we can. Support that decision-making process, that medicine investigatory process as much as we can. We also have our continuous learning process, which is kind of that, that culture where instead of looking at the mistake, we strive to continually learn and improve the system. Both of those are dependent on a reporting culture, though. And I think when it comes to diagnostic error, we need to make sure that we've identified a means to identify and report diagnostic error when it happens. And that gets a little tricky because there can be a real lag sometimes when something's missed to where it's identified, or when it's misdiagnosed to its corrected and correctly diagnosed. But that means we just have to be that much more diligent in our reporting culture. I also think it's important, with a complex process like this, you can't just have diagnostic error adverse event. You really need to categorize these events so that you can start to work your way back through the system, understand the specific elements and contributing factor around that cohort of errors, and then that opens up doors for improvement recommendations for that piece. Truly, I don't think there's a magic solution out there that's going to make, remove all diagnostic error from the situation and just create diagnostic safety for everyone. What we do need to do, though, is approach in that continuous means, always learn from the process, identify more risky situations. Certainly dementia has a certain level of risk when it comes to diagnosing, but as we age, there's other disease processes that can be just as tricky to get a clear, quick diagnosis and get a treatment plan in place. So I still believe in my heart, when we go after things with that systems approach and stop looking for a magic fix, but treat it with the respect it deserves. It's a process. It involves a lot of moving parts. It involves our abilities as human beings. It involves some of our limitations as human beings, and we just want to make sure we build systems that support good diagnostic reasoning as much as possible.
Vic, thanks so much for joining us today.
It's truly my pleasure to be here, Paul. Thank you.
Thanks for watching ECRI Now. You can find more insights from the experts on YouTube and at ECRI.org. Until next time, I've been your host, Paul Anderson.